Getting pregnant naturally in your 50s is incredibly rare.
Yeah, exceedingly rare.
Right. But because of modern medicine, millions of women have absolutely no idea when they've actually crossed the finish line of menopause.
Exactly. They're completely in the dark.
I mean, you have a situation where the biological risk of spontaneous conception is plunging, sure, but the medical and social consequences of an unintended pregnancy in that specific decade are, well, they're uniquely high.
Oh, absolutely.
And layered on top of all of that, you have overlapping prescriptions for symptom management that completely obscure what the reproductive system is actually doing. So welcome to today's deep dive. We're looking at a stack of clinical protocols today, specifically guidelines from the UK's Faculty of Sexual and Reproductive Healthcare, the HSE, and primary care frameworks.
It's a heavy stack of reading, for sure.
It really is. And our mission today is to answer a single, incredibly complex question for you. At exactly what age and under what clinical conditions can a woman over 50 safely stop using contraception?
Well, the perimenopausal transition creates this absolute crossfire of clinical objectives. You have patients who are just utterly exhausted by decades of contraceptive management, and they're desperate to just stop taking anything.
Right, they just want to be done with it.
Exactly. But because the physiological shutdown of the ovaries is so erratic, identifying that safe endpoint requires untangling a lot of competing hormonal timelines.
So to untangle those timelines, we first have to strip away all the medications. Right. Strip away all the synthetic hormones and just look at the absolute biological baseline.
Yeah, the natural state.
And the guidelines provide a very clear anchor point for this,
Yeah.
which is age 55. That is the universal finish line.
The absolute cutoff.
Yeah. Regardless of what methods are being used, all women can generally cease contraception at age 55 because spontaneous conception past that point is exceptionally rare. I mean, even if there is still some occasional menstrual bleeding occurring.
Right. Age 55 provides the medical consensus for when natural loss of fertility can just be safely assumed.
Okay.
But the average age of menopause is much earlier. It's hovering around 51 in the UK, for example.
Wow, okay.
So we have this multi-year gap where a patient might be fully menopausal but still needs clinical proof before safely dropping her contraceptive coverage.
That makes sense.
If a patient is completely hormone-free, so relying on barrier methods, maybe a copper IUD or natural tracking, we rely on amenorrhea, just the absence of periods.
The natural rules.
Yeah.
And the guidelines split the timeline here based on age, don't they?
Yes, they do.
So if a patient is over 50 and completely hormone-free, she can safely stop contraception after 1 full year without a period.
Correct.
But if she is under 50, she has to wait 2 full years. I mean, 55 is like the final buzzer of a game. Correct?
I like that.
No matter what, it's over. But the 1-year and 2-year rules are like a mandatory cool-down period to prove the game actually ended early.
Yeah, that's a great way to look at it. What's fascinating here is the biological mechanism driving that age split.
Okay, tell me about that.
It basically comes down to the way the ovaries fail. It's not a sudden linear decline. The ovaries act more like a flickering bulb before it finally burns out.
Oh, wow, okay.
Yeah, in patients under 50, ovulation during perimenopause becomes highly erratic. The hypothalamic pituitary ovarian axis, which is basically just the communication loop between the brain and the ovaries, it's sputtering.
Right.
So a patient might go 8, 9, or even 10 months without a cycle, leading her to believe, I'm menopausal.
Yeah, you definitely think you were done.
Exactly. And then suddenly an ovary releases a rogue egg.
Oh, man. So the 2-year rule is essentially a mandatory cool-down period to ensure that flickering bulb is completely dead.
Yes.
Just
right.
totally avoiding a false finish line.
Exactly. The clinical evidence proves that an extended, strict 2-year wait is absolutely necessary to clear the window of erratic ovulation for those younger perimenopausal patients.
Got it.
But once a woman crosses the threshold of age 50, the biological probability of those rogue ovulations drops so precipitously that a 1-year wait becomes statistically safe.
That makes perfect sense if you are hormone-free. I mean, your body is allowed to send its natural signals, you observe the cessation of bleeding, and you apply the timeline.
Right. It's very straightforward.
But the sources highlight a massive complication here, which they call the masking effect.
Oh, yes. The masking effect is huge.
Because a huge percentage of women in their late 40s and early 50s are not hormone-free, are they?
No, not at all.
Yeah.
They are actively utilizing hormonal management. So the pill, the patch, the implant, the ring. And hormonal contraception fundamentally alters natural bleeding patterns. Depending on the method, it might induce irregular bleeding or it might induce total amenorrhea.
Total stoppage.
Right. So if you're taking a continuous hormonal medication and you don't have a period for 14 months, you cannot assume it's due to ovarian failure.
Ah,
It is highly likely just the exogenous hormones suppressing the uterine lining.
it's like wearing noise-canceling headphones.
Oh, that's a perfect analogy.
Yeah, like your ovaries are making their natural noise, sputtering, slowing down, trying to send those menopausal signals. But the medication is playing artificial music so loudly over it that you cannot hear what your biology is actually doing.
Exactly. Your natural cycle is completely masked.
And because of this masking effect, the guidelines establish age 50 as a highly critical medical pivot point.
Yes, a very strict pivot.
The protocols state that at age 50, combined hormonal contraception, which includes the combined pill, the patch, and the vaginal ring, is just no longer recommended.
Right.
They also emphasize stopping the progestogen-only injection, the DMPA shot. Women hitting 50 on these methods have to transition to a progestogen-only pill, an implant, an IUD, or a non-hormonal method.
That's the protocol, yeah.
Okay, let's unpack this for a second because I'm genuinely confused about something here.
Okay, sure.
We just established that menopause involves a steep drop in estrogen. And if things like hormone replacement therapy exist to give you estrogen back, why are we abruptly pulling women off the combined pill at 50?
It's a really common question.
I mean, isn't the pill just delivering estrogen too? Why is one a severe hazard and the other a standard treatment? Does the body magically change overnight at 50?
That's entirely valid to ask. If we connect this to the bigger picture, the distinction lies in the compounding nature of vascular risks and the type of hormones being utilized.
Okay.
Aging is obviously a gradual process, but clinical protocols require clear, actionable thresholds. As a patient ages, baseline cardiovascular risks, things like blood pressure, arterial stiffness, they naturally increase.
Right, just getting older.
Exactly. And combined hormonal contraception relies on synthetic estrogen. This synthetic estrogen carries a specific dose-dependent increase in the risk of venous thromboembolism or blood clots.
Oh, I see. So is the specific synthetic estrogen in the combined pill adding a layer of clotting risk on top of the naturally increasing age-related cardiovascular risk?
Precisely. By the time a patient hits 50, that compound effect shifts the risk-to-benefit ratio entirely out of her favor. We have highly effective, safer contraceptive alternatives that completely omit estrogen, like the progestogen-only pill or the implant. The goal is to remove the unnecessary blood clot risk while still maintaining the contraceptive barrier.
Okay, that makes sense for the combined pill, but what about the injection?
Right, regarding the DMPA injection, the mechanism of concern at age 50 actually shifts to skeletal health.
Bone density.
Yeah. The injection heavily suppresses natural estrogen production, which in turn lowers bone mineral density.
Oh, yikes.
And women entering their 50s are already facing an age-related decline in bone mass due to the perimenopausal drop in estrogen.
Right, of course.
So keeping them on a contraceptive injection that actively exacerbates bone loss creates a double hit to the skeleton.
A double hit. Wow. So it's a pivot to safer tools because the vascular and skeletal terrain of the body has permanently altered. So a patient hits 50, her doctor pulls her off the combined pill to avoid the blood clot risk and switches her to a progestogen-only pill. But those progestogen-only methods also mask natural bleeding, don't they?
They absolutely do.
So she's sitting there with her noise-canceling headphones still firmly on, her periods are stopped by her new medication, and she has no idea if she is actually menopausal or still fertile.
She's totally blind to it.
How does she know if she actually has to keep taking this new pill until she is 55?
Well, medical science does have a diagnostic tool to try and peek under those headphones, which is the follicle-stimulating hormone blood test, or FSH test.
Right.
But, and this is a big warning, it is perhaps one of the most misunderstood and misapplied tools in perimenopausal care.
Yeah, the guidelines are incredibly strict about when this test can actually be employed. The criteria state the FSH test is only useful for checking menopausal status in women who are over 50, who are completely amenorrhoic, and who are actively using progestogen-only methods, so the mini pill, the implant, or a hormonal IUD. How does checking FSH actually tell us what the ovaries are doing?
It relies on that feedback loop we mentioned earlier. When the ovaries begin to fail, they stop producing sufficient natural estrogen.
Okay.
The brain's pituitary gland senses this deficit, In response, it starts pumping out drastically higher levels of follicle-stimulating hormone, trying to stimulate the ovaries back into production.
Like it's turning up the volume.
Exactly. A high concentration of FSH in the bloodstream is essentially the brain screaming at ovaries that are no longer capable of listening.
Wow. So what is the mathematical threshold the guidelines look for? Like when does the doctor say, okay, the ovaries are officially done?
A single FSH reading greater than 30 international units per liter is the clinical marker for ovarian insufficiency.
Greater than 30.
Yes. But that reading does not grant immediate permission to abandon contraception. It just serves as a warning marker.
Right, because the guidelines include a strict safety buffer here. Even with an FSH level above 30, the patient must continue her progestogen-only contraception for exactly 1 more year from the date of that blood draw.
Correct. That single high reading confirms the systemic shutdown has begun, but it cannot guarantee immediate permanent sterility.
Because of the sputtering.
Exactly. Adding the 1-year buffer safely covers the risk of any final erratic ovulatory events. After that specific 365-day period, she can cease contraception permanently, well before her 55th birthday, and she never needs to undergo the blood test again.
That's great. What if the test comes back under 30?
If it's under 30, she's likely not menopausal yet. She just continues her current progestogen method and can either retest in a year or simply ride it out to the 55 finish line.
Here's where it gets really interesting, though. The entire system falls apart if this test is used incorrectly.
Oh, it completely falls apart.
Because the sources emphasize the absolute invalidation of the FSH test for anyone using combined hormonal contraception or hormone replacement therapy.
I see this constantly in practice, honestly.
Really?
Yes. A patient experiencing hot flashes will come in and request a blood test to confirm menopause. But if she is currently taking combined hormones or HRT, running an FSH panel is worse than useless.
Worse than useless.
It's actively misleading. This raises an important question about how we educate patients on their own prescriptions.
It goes back to the dashboard of the body. I mean, if the FSH test is this check engine light telling you the ovaries are failing, taking combined hormones or HRT supplies the body with exogenous estrogen.
Right.
The brain senses those synthetic hormones floating around in the bloodstream and assumes the ovaries are functioning perfectly. The pituitary gland doesn't bother pumping out the FSH.
Exactly.
You've essentially unplugged the dashboard. The check engine light will not turn on, even if the engine has completely permanently stalled out.
The exogenous hormones suppress the natural FSH response. So a practitioner drawing blood under those conditions will receive an FSH reading that looks perfectly normal, falsely suggesting the patient is highly fertile and far from menopause.
That is so dangerous.
It really is. Applying this knowledge correctly prevents massive amounts of clinical anxiety. It saves the patient from invasive needle sticks, and it prevents the healthcare system from wasting laboratory resources on panels that yield completely null data.
So if the blood test is completely useless for anyone on combined hormones or HRT, it seems like the most practical clinical move is finding a set-it-and-forget-it option,
Yeah, ideally.
Something that just carries a patient safely over that absolute finish line at 55 without needing constant monitoring. Which brings us to the long-acting devices.
Ah, yes.
The guidelines build in some incredible clinical efficiencies for women over 40 using these specific tools.
They do. The lifespans of intrauterine devices change significantly as a woman ages.
How so?
This is largely because the natural background fertility rate in the general population is dropping.
Right.
Which reduces the absolute statistical risk of a pregnancy occurring even before clinical menopause is fully achieved.
Okay, let's look at the copper IUD, the non-hormonal option. The protocols state that if a copper IUD is inserted after a woman turns 40, she does not need to have it removed and replaced every 5 or 10 years.
Correct.
It can remain in place, actively providing contraceptive coverage all the way until she turns 55.
It's an enormous logistical convenience. An insertion at age 41 essentially covers the remainder of a patient's reproductive lifespan.
That's amazing.
It is. However, the guidelines include a critical caveat here. These devices cannot be left in utero indefinitely.
Oh, right.
Once a patient crosses 55 and the device is no longer required for contraception, it must be extracted. Leaving a foreign object in the uterus indefinitely post-menopause creates a localized focus for serious infection.
Good to know. It's a bridge to 55, not a permanent implant.
Exactly.
And the timeline for the hormonal IUD is similarly extended, specifically the 52 milligram levonorgestrel IUD, which, well, a lot of people know it by brand names like Mirena.
Yes, very common.
If a 52 milligram LNG IUD is inserted after a woman turns 45, it can remain in place for contraception until age 55.
Again, this spares the patient from undergoing another potentially uncomfortable insertion procedure in her early 50s, bridging the gap precisely to the universal endpoint.
But introducing the hormonal IUD brings us to one of the most dangerous myths in perimenopausal care.
Oh, yes, the HRT myth.
It's an overlap that causes profound confusion. We have to talk about hormone replacement therapy and the assumption that because HRT involves hormones, it functions as birth control.
It is a terrifying misconception.
The guidelines are adamant on this point. HRT is not contraception. Why does the combined contraceptive pill completely shut down fertility, but hormone replacement therapy does not?
It is entirely a matter of biological dosage and pharmacological intent.
Okay.
The combined pill delivers a high concentration of synthetic hormones designed specifically to suppress that communication loop, forcibly halting ovulation.
Right, overwhelming the system.
Exactly. HRT, conversely, utilizes a very low dose of hormones. The intent is merely to replace the baseline estrogen the failing ovaries are no longer producing.
Just enough to alleviate the symptoms.
Yes, just enough to stop severe vasomotor symptoms like hot flashes, brain fog, and joint pain.
It's a top-up, not a shutdown.
Exactly. The hormone concentration in standard HRT is simply not potent enough to reliably override the reproductive system. Clinical data indicates that standard HRT only inhibits ovulation in roughly 40% of patients.
Meaning 60% of women on HRT are still actively ovulating and fully capable of conceiving.
Yes.
Relying on symptom management medication to prevent pregnancy is essentially flipping a coin. And as we established right at the beginning, the medical risks of a spontaneous pregnancy in your 50s are severe.
They really are.
So you have a patient taking HRT to survive her hot flashes, but she hasn't reached menopause yet. She urgently needs contraception, but she's already taking systemic hormones. Does she just stack another pill on top?
She can. The guidelines confirm that all progestogen-only contraceptive methods are chemically safe to utilize alongside HRT.
Okay.
A patient can apply her HRT estrogen patch to manage her systemic symptoms and simultaneously take the progestogen-only mini pill or utilize the contraceptive implant to maintain an effective barrier against pregnancy.
So they don't fight each other.
No, they do not dangerously interact or compound the vascular risk the way combined estrogen pills do.
But the sources reveal an absolute gold standard here, a true multi-tool for women's healthcare in this specific transitional decade. And it involves that 52 milligram hormonal IUD we just discussed.
It really is a game changer.
So what does this all mean for you?
Well, to understand why the IUD is so effective here, you have to look at how standard HRT is prescribed. If a woman still has her uterus, HRT requires two distinct components.
Okay.
She needs the estrogen to relieve her menopausal symptoms. But unopposed systemic estrogen thickens the endometrial lining of the uterus, which significantly increases the risk of endometrial cancer.
Oh, wow.
Therefore, to protect the uterus, she must also take a progestogen to keep that lining thin and stable.
So a patient in her early 50s needs contraception to prevent pregnancy, she needs estrogen to stop the hot flashes, and she needs progestogen to protect her uterus from the estrogen.
Yes.
That is three separate physiological jobs.
And the 52 milligram LNG IUD is uniquely designed to handle two of those jobs simultaneously.
That's brilliant.
It is. A patient can have the device inserted where it functions as highly effective, localized contraception. Her practitioner can then prescribe an estrogen patch or gel to manage the vasomotor symptoms.
Right.
Because the IUD continuously releases progestogen directly into the uterine cavity, it perfectly serves as the vital protective component of her HRT, keeping the endometrial lining thin.
It's an incredibly elegant clinical solution. I mean, you aren't forced to juggle 3 different prescriptions or worry about conflicting systemic side effects.
You know, it streamlines everything.
One single localized device manages the fertility risk and acts as the safety anchor for the symptom-relieving estrogen therapy. It is exactly this kind of nuanced overlap that completely changes the experience of perimenopause for you.
It streamlines the pharmacology beautifully. However, the guidelines stress one critical, non-negotiable detail regarding this dual-use scenario.
What's that?
We noted earlier that a 52 milligram IUD inserted after age 45 is approved for contraception until age 55.
Right, the 10-year bridge.
But if a patient is utilizing that exact same IUD for HRT endometrial protection, the rules fundamentally change. For HRT protection, the device must be replaced every 5 years, regardless of the patient's age at insertion.
Wait, really? So why does it last 10 years for one job but only 5 for the other?
The mechanism of the device involves a slow decline in the amount of hormone released over time.
Okay.
The progestogen levels drop slightly as the years pass. By year 6 or 7, the concentration is still high enough to thicken cervical mucus and prevent pregnancy. But it may no longer be robust enough to fully suppress the endometrial lining against the continuous influx of exogenous HRT estrogen.
Oh, that makes sense. Contraception is good until 55,
Yeah.
but HRT protection requires replacement every 5 years.
Mhm.
That is exactly the kind of highly specific mechanism that allows a patient to actively advocate for her own health outcomes.
Absolutely. Knowledge applied correctly is everything.
We have covered a massive amount of clinical ground today. Let's recap the primary takeaways. First, the absolute biological finish line.
Why?
At age 55, contraception can safely be abandoned by everyone.
Every.
Before that, if you are completely free of all hormones, you are waiting for the natural signal of amenorrhea. 1 year without a cycle if you are over 50, 2 years if you are under 50 to account for that erratic ovarian flickering.
We then explored the masking effect and the age 50 pivot.
Right.
Because exogenous hormones obscure natural bleeding, 50 is the mandated age where the compounding vascular risk of blood clots and the skeletal risk of bone density loss require patients to stop the combined pill and the DMPA injection.
Transitioning entirely to safer progestogen-only or non-hormonal methods.
Exactly.
We decoded the mechanics of the FSH blood test. We learned it is only medically useful if the patient is over 50, has no periods, and is utilizing a progestogen-only method.
Yes.
A score over 30 means the brain is shouting at the ovaries, requiring a patient to wait exactly 1 more year before stopping contraception.
Yeah.
And we saw how utilizing the combined pill, or HRT, completely unplugs that dashboard, rendering the test useless.
Absolutely useless.
Finally, we clarified that low-dose HRT is absolutely not birth control, but the devices like the hormonal IUD can brilliantly manage both contraception and endometrial protection simultaneously.
It is a deeply complex algorithm, but it is entirely logical once you map out the underlying physiological mechanisms of what the ovaries and the hormones are actually doing. And observing this interplay brings up a much broader consideration for you to think about. Modern medical science has successfully extended our health span and actively delayed the traditional physiological markers of aging.
Yeah.
We now exist in an era where aggressively treating the debilitating symptoms of menopause with therapies like HRT often overlaps directly with the necessity to manage a prolonged, active window of fertility.
Patients are vibrant, active, and requiring sophisticated fertility management much later in life than previous generations ever considered.
What does it mean for our societal timelines of getting older, when the biological capability and the intensive clinical management of fertility demands our active, careful attention well into our mid-50s?
That's a huge question.
We are essentially redefining the timeline of womanhood, pushing the boundaries of what it means to transition through midlife.
Redefining the timeline and finally understanding exactly where that biological finish line is drawn. Thank you for joining us on this deep dive into the clinical guidelines. Keep questioning the mechanisms of the world around you. Keep advocating for your own health, and we will see you next time.